Hi, everyone, and welcome to the SRHM podcast, which explores new research and emerging trends in the field of sexual and reproductive health and rights, with a focus on using rights-based knowledge for action. My name is Nina Sun, and I am an associate editor for the SRHM Journal. Welcome to the Sexual and Reproductive Health Matters podcast. It's Friday, and we're back with another important conversation that demands attention. Today, we're tackling a pressing issue: the maternal health disparities faced by Black and Latine women, and how systemic barriers within healthcare contribute to these inequities. We're honored to have two special guests with us today: Lucia Guerra-Reyes, Associate Professor, and Ruhun Wasata, PhD candidate, both affiliated with the Department of Applied Health Science, School of Public Health, Indiana University in Bloomington. They are a few of the authors of the compelling new study published in the SRHM Journal, Provider Perspectives on Maternal Care Challenges for Black and Latine Women in Indiana. This study explores the systemic barriers that Black and Latine women face in accessing quality maternal health care in Indiana, based on interviews with 32 healthcare providers. The findings highlight key challenges, including implicit bias, cultural misunderstanding, socioeconomic obstacles, and lack of provider diversity. The research underscores the urgent need for policy reforms, cultural competence training, and community-based solutions to improve maternal health equity. Stay with us as we discuss the critical findings of the study, the gaps in maternal health care that need urgent attention, and what must change to ensure equitable and just care for all. So first of all, thank you, Lucia and Ruhun, for making the time to speak with us today about your paper.
Thank you for inviting us.
Thank you for having us.
Of course. So to begin, Lucia, can you speak a little about the rationale behind the study? What were the gaps in knowledge or the gaps in healthcare practice that you wanted to address? And finally, why was it important to publish on this topic, particularly in the context of maternal health disparities in Indiana?
Yeah, so this study was born of me trying to understand specifically the context of maternal health in Indiana. This was something that happened during the pandemic. So I was trying to get my head around how to understand what the ecology of maternal care was, what the organizations were, what work they were doing in terms of maternal health in Indiana. I was always concerned about the issues, especially the very stark disparities of maternal deaths, specifically in Indiana. My prior research was around policies around maternal mortality in Peru. And so this was an issue of concern to me. Indiana's maternal health overall is not great, right? Even on average, it is third from last in terms of maternal mortality in the 48 contiguous United States. So I wanted to understand what was out there, right? What the ecology of the systems were. And in doing that, I realized that it was during the pandemic. So even though we wanted to talk to women about their own experiences, we thought that provider perspectives might be equally important, especially as they pertain to trying to understand or influence or work with policymakers, right? So because providers have the expertise not only of one experience, but many experiences of people that work with them. So it was this gap in knowledge. We didn't have any data on provider perspectives regarding their own clients who were marginalized communities. And through this kind of ecological research, trying to find out all the providers and what they did, we were able to gain some insight into what they saw as the main problems.
Thank you. That's really fascinating to hear about the process of how this paper developed. In terms of the specific findings of the research in the paper, were there any specific results or findings that stood out to you personally or that surprised you?
Yes, and I am also going to ask Ruhun to chime in here. I don't know that there was things that surprised me. There was in the literature in other places in the United States a very clear indication of structural biases and racism and the anti-immigrant climate in terms of policy and access to public funded care that I saw in other research in other parts of the US. And so I kind of thought that is what we were going to find here. And it did. The strength of the thing that really, on the one hand, didn't really surprise me, but really warmed my heart was that there is in community members, because in terms of providers, we didn't only interview health providers in clinics, but also people who were providing maternal care in communities. So we interviewed doulas, we interviewed lactation consultants. It was really great to see that there was this nascent, burgeoning group of mostly marginalized women who were providing services to the community and who were really filling the gaps that the clinical care facilities were not. I mean, it's not enough, but it's great to see that there's work going on and trying to do my best to support that kind of work.
I would like to build on what Lucia said, that while working here in the US, it is probably understandable that how health care services are different for people coming from various backgrounds. However, for me, as I just started my studies in the US, I came from another country. For me, things were different, as in, I have always thought, or I have always known, that US is the model of healthcare access, US is the model of human rights, all those things. So when I started working on this project, a lot of these things were pretty much surprising for me, because I started learning about the healthcare inaccessibility, healthcare disparities from a more closer perspective. The one thing that stood out for me was seeing that how the citizenship restriction, how the citizenship documentation, those were impactful for persons for receiving healthcare services. For example, if you are not a citizen, if you are not a permanent resident, if you're not a legal citizen in the US, you are not able to receive different assistance related to maternal health care. The people who are undocumented, who cannot have things such as women, infants, and children program services, they cannot receive those benefits. They cannot also receive the service of nurses going to the home and homes visiting maternal and child care service program. So that was very interesting for me to see. The other thing I would say that stood out for me is that it was not only related to the specific programs or policies, it was actually related to all of the layers of the society, that women were experiencing disparities because of their race, because of another ethnic representation. That was like a trickle-down effect for the health disparities in healthcare services for maternal healthcare, particularly in India. Those two things definitely stood out for me.
So one of the things that I think is important to understand is that Indiana has had a very has a lot of restrictions on people who are undocumented. And in the rest of the US, there's varied restrictions in different parts of the United States. But the restriction for women, infants, and children, Women, Infants, and Children is an organization that provides food for breastfeeding mothers. They also provide advice as to how to breastfeed, and they lend out pumps. And for children who are not breastfed, they also provide formula. And in the rest of the United States, this is a federally funded program, and there's no citizenship requirement. In Indiana, for a long time, there was a citizenship requirement. Actually, not necessarily a citizenship requirement. There was an expectation that the person that was coming to the Women, Infants, and Children declare that they were eligible as citizen or they had legal status. And then this would count against them in any normalization of citizenship procedure. So if they wanted to normalize their immigration status, having received money from women, infants, and children would be considered on the sort of a black check mark of being a burden. They had received undue things from the United States. And so people could still get it, but there was a lot of fear about it. In the year 2022, this was reversed by the Indiana State Department of Health. However, the climate in the United States and in Indiana, more specifically, has again turned very, very much anti-immigrant, and there's not a lot of knowledge of where this is going to go. The other thing that I think is important that Ruhun mentioned or sort of alluded to is representation. So there are very few nurse midwives who are non-white in Indiana. So that means that in the clinic, you have very, very few potentials of seeing providers that understand your culture, that understand you. When we did the research, I went to a meeting of the Nurse Midwifery Association of Indiana to kind of recruit some minority midwives so that we could talk to them. And they told me there were about 5 Black midwives that were part of their association in Indiana. They actually knew them by name, right? And we weren't able to talk to, at least, I think we were able to talk to one of them. So there's a lack of representation at the clinic level when you go to the clinic in terms of Spanish speakers, in terms of people who understand some of the more specific cultural needs of women during pregnancy and labor.
Thank you. You've both really outlined some insightful results that I think for many people who are unaware of both the healthcare system in the United States and specifically Indiana, as well as maternal and child healthcare organizations and how those systems operate, you've both given a lot of insight into the complexities of how these systems work. So based on these findings, and Lucia, you've alluded to kind of this current changing climate, where do we go from here? What do you see as the next steps for really acting on the research that you found, the evidence that you've gathered in terms of improving maternal health care for Black and Latina women?
So if I had my druthers, right, if I could change everything, because I don't know that we can, but I think that one of the things that, because there's strict policies in terms of the state itself. So while I think that policy change is important and that we really need to push for more inclusive policies, the current climate is not in its sort of best space to do that. So I think that there's 2 avenues, and Indiana has been working on one of them, and there's organizations in the state that have been working on birth equity and on trying to change the laws. So, for example, doulas are now theoretically allowed to be paid by Medicaid, but there has been no funding attached to this in the budget in the state legislature. However, it has been approved, so there's movement towards trying to get that funded. And so I think that's one policy change that would be significant, because there are projects and programs that support doulas for both Latina and Black women in the clinic. So these are women who accompanying them through pregnancy, but especially in the specific labor process in the clinics, where we see most of the issues that others have talked about, right? The violence, the discrimination, and things that happen in the clinic. For that, Dana Ain Davis has a great book. I don't remember the book name right now, but these are the issues that happen within the clinic sphere. So having doulas there as support is a great way, though not a systemic way to deal with this. I think a second tier is the organizations themselves. So the way that the United States health system is organized, there is no public health system. So, for example, I'm from Peru. In Peru, we have like the private health system and the public health system. And the public health system is managed by the government. And this is not the case in the United States. So you have health organizations, and these health organizations manage hospitals and clinics in specific geographical locations. So there is the opportunity to lobby these health organizations to revise some of their policies and some of their own functional sort of organizational requirements that will alleviate some of the issues that we have talked about. For example, the issue of representation, right? So you could try to hire more Spanish-speaking Latine and Black people into your organization. You could modify some of those sort of legacy rules that really discriminate against women who are on the marginalized sides of the spectrum. So this idea, for example, that if you're 15 minutes late to your appointment, then your appointment is canceled. But if you don't have a car, or if you have to depend on the bus system, or there's a series of sort of transportation barriers, then that really affects marginalized women more. So these are changes that can be made at the organizational level. And I think we continue working on trying to get those big changes made. Like there's people in the state legislature who are working towards trying to, for example, get some form of allowance for breastfeeding women in the workplace. However, it is a Republican supermajority right now. But the work continues, right? Not because they say, no, we're going to stop asking. So I think that those are the things we need to do now. If I could, I would change all the policies and make them more inclusive. But I don't know that that's in the cards.
Thank you. So that was a hard question to answer, especially in the current environment. So I thought that was great. All of your thinking of how we can work even in a context that is maybe less open to the broader policy changes that one could originally envisage. So my final question for both of you today is, how do the insights from this specific research study connect with broader national or global conversations related to maternal health equity?
When Ruhun said before that when she started, this was her second year in her PhD program when we started working on this, but I've been in the US longer. But the sort of surprise of, well, maternal health should be better because we are, as a country, investing so much money into healthcare and spending so much, yet health is not a human right. I don't see a real wholesale buy-in in the United States, even before this whole sort of more conservative climate, that a recognition that health is a human right. And I think that's where we connect to these broader discussions, right? So if we as a society recognize that health is a human right, then ethically, morally, and also because of our belief in the needs of people to live well-supported lives, we are supposed to do, as a society, things to be able to have people attain this health as a human right. So this research, and I think research from many other people who have done studies on what is really a crisis of Black maternal mortality in the United States, are very much supporting this idea that we need to think about this at center, health as a human right, and that we need to think about forms of institutional and policy change that bring back a form of justice in terms of the relationship between marginalized women and the clinics. This contestation, these problems, these sort of conflicts or issues of marginalized women and the public health systems are things that you see in very many parts of the world, right? So there has been a lot of movement from the United Nations and international funding to work towards improving maternal health for marginalized populations in other parts of the world. In Peru, where I'm from, during the 1990s and the 2000s, et cetera, the Safe Motherhood Initiative, with funding from the United States and others, pushed things like culturally appropriate care and the importance of culturally appropriate care in the clinic. And I think that policymakers in the United States, interestingly, have to look at what things have worked abroad to see how they can implement some of those changes here.
I will add to what Lucia said, and Lucia actually has given me a really good segue for the things I wanted to say. Maternal health care is a very global thing. It is not only an issue in the US, it is an issue, it is a challenge all over the world, because maternal care is one of those factors which is very much influenced by the culture you are coming from, the structure you are operating in, the resources you have, as well as the family you are working with. So there are so many factors that play for maternal health that we cannot provide an one size fits all prescription for this very specialized, very specific aspect of healthcare in general. In terms of how our work is associated with the global perspective or global conversation on maternal health equity, and I would like to build on or go back to what Lucia said, that we have to look into other countries where things are more positive, where there are success stories, evidence based success stories for maternal health equity. That is one of the first thing. And we need to think about how can we integrate traditional knowledge and practices, because as I have been talking about, maternal health care is very much influenced by the cultural practices, the cultural structure that we operate in. For different cultures, the traditional knowledge of pregnancy, the traditional practices of birth is very different. So that is something we always need to think about while operating in one specific context. The second thing is that because of the differences in cultural practices related to pregnancy, giving birth, we have to have very tailored communication strategies, as in what might be impactful in having a conversation with the Latin communities in the US that might not be appropriate for maybe South Asian communities currently living in the US, or maybe South Asian communities who are in other countries around the world right now, or a very specific South Asian country in one of the South Asian countries right now. The third thing is that we always need to incorporate the community leaders. And these community leaders can be anyone. They are not only the religious leaders, they are other sorts of leaders, such as one school teacher who has very good acceptance, and that person can provide nuanced messages on how to have a better maternal health care for marginalized communities. The other thing is that, particularly in the recent time, in the contemporary times, we are seeing that although the idea of border is becoming more and more prominent, the challenges of borders are becoming increasing, right? We can see in Latin America hundreds and thousands of women from Venezuela and other countries, in Peru, for example. The practices that were prevalent in Venezuela that might not be exactly the same in Peru for maternal health care. So we need to integrate persons from all of these countries to work on cross-border facilities, to work on cross-border organization, so that these people who are migrating from one country to another country for many reasons, that can be a reason related to economic crisis, that can be a reason related to anything, political issue, for these persons, we need to create a safer space. And that is the reason we have to have persons working in this organization who are more affluent in cross-cultural understanding, cross-border understanding. So these are the ways I think our work provides insight that how maternal health equity is not only a US specific thing, but it can also be translated in other contexts.
As an aside, I used to joke that we were doing global health research because I'm from Peru. Another person in our paper is from Venezuela. Ruhun is from Bangladesh, and there was only one person who was a US person on our team. So we were actually doing research on the US, but we were looking at this really very much from our own experiences of research and life. So that was fun, though we couldn't call it global health, but yes.
I would like to actually add to what Lucia said, because I just remembered for some other reason I was looking into the data Bangladesh has on maternal health care. And Bangladesh is one of the extraordinary examples that even though we have a very large number of population, Bangladesh is currently 8th densely populated country in the world. Even though we have a very limited resources, we are a resource poor country, Bangladesh has made remarkable success in reducing maternal mortality. And we have received accolades from United Nations, World Health Organization, from those places. So what has worked is to create a policy around the culture. We started after the independence of Bangladesh in 1971, we started giving this message that what loosely translates in English is one child is best, but no more than two children. And the government was actually going to the remotest place in our country to provide contraceptive and bringing female from that specific community to help the women of those communities to have that conversation around contraceptive. So this type of element in the maternal healthcare was helpful for our country. So how that can be translated in other countries? This is how the global conversation on maternal health equity is very relevant and important.
Thank you, Ruhun and Lucia. Absolutely. Any work done in Indiana in the US often has global implications and lessons learned that can be taken both ways, right? Both from other countries, amongst other countries, and within the US, of course. So thank you both for being a vital part of this conversation today. Maternal health disparities, especially for Black and Latine women, demand our continued action, advocacy, and attention. If you want a deeper dive, check out the show notes. You'll find a link to the full study as well as details on how to engage with SRHM Journal, as well as publish more research on this important topic. As the authors of this paper highlight, to address maternal health disparities, we must go beyond individual interventions and tackle the structural inequities that continue to shape healthcare experiences and outcomes for marginalized communities. Let's keep this conversation going. And until next time, take care. Thanks for joining us for this insightful conversation. Please check the show notes for a link to the SRHM Journal, which is available online and open access. Follow us on social media and sign up for our newsletter to receive notifications for new publications. If you're enjoying this podcast, please subscribe, give us a rating, or leave a review. Sharing evidence-based and rights-grounded knowledge is our passion, and it's also critical to support the advocacy and actions that need to be taken to improve SRHR for all. We would very much appreciate it. Thank you for supporting the SRHM podcast, which is produced by our staff. The music was composed by Tiber Christian and Salomon Beautombe.